There we go. And we ask that you please keep your microphones muted during the presentation. So let's learn a little bit more about our speaker. Claire Webster works in collaboration with the Division of Geriatric Medicine and the Faculty of Medicine and Health Sciences at McGill University. She's the founder and ambassador of the McGill Dementia Education Program and McGill Cares, a webcast series designed to support family care partners. Claire is a certified dementia care consultant and certified professional consultant in aging, a conference speaker and educator in the field of caring for an individual with dementia. She's the founder and president of Caregiver Crosswalk, a consulting firm that provides education and support services to help individuals navigate the journey of Alzheimer's disease and other dementia-related illnesses. As a former care partner to her late mother, who had Alzheimer's disease, Claire has lived experience on the impact of this disease on a person living with dementia and the ripple effect on the family members. Claire is one of the senior co-editors of Alzheimer's Disease International's World Alzheimer Reports for both 2021 and 2022. She's also a member of the Government of Canada's Ministerial Advisory Board on Dementia. And most recently, she was awarded the King Charles III Coronation Medal for her dedication to advancing dementia education and support for caregivers. Claire, please go ahead.
Well, thank you very much. And I'm very happy to be here with all of you from rainy Hatley, Quebec. And what's wonderful about these Zooms is that I could be speaking to people in beautiful British Columbia. I have to say that of all the work that I do, giving lectures like this one is what I enjoy the most, because I get to speak and educate many people at once. And I hope that by the end of this hour or so, you will all be more or less dementia experts, and you'll go and share this knowledge with others. So I do this work as a result of my own journey as a former caregiver to my late mother. I was a caregiver for 10 years who was diagnosed with Alzheimer's disease. And prior to 2006, I knew absolutely nothing about dementia. So if you would have asked me 20 years ago if I would have been doing this work, the answer would have been like, no way. Like I would have never imagined doing this work. So sometimes our life's journeys will appear in unexpected ways. And so when my mother was diagnosed with Alzheimer's disease, the only information that we received from the medical doctor was, good luck, Mrs. Webster. That was it. There was no, okay, this is the diagnosis and here are the next steps. So as you can imagine, you know, in the work that you do, if somebody's diagnosed with cancer or other types of illnesses, there's a plan, right? There's a plan of what to do next, the treatment options, how to, you know, where to go. But very sadly, oftentimes when it comes to dementia, the patient and the family will hear, well, good luck, see you in 6 months. It's normal aging, and dementia is not normal aging, by the way. So that was my situation, and as a result of these 4 words or 3 words, it really set me on the path that I am on today, because I was really not prepared for the journey of caring for my mother. So I'm going to be talking a lot about the ripple effect that the disease has. It has a ripple effect not only on the person that's diagnosed with all of the different symptoms that I'll be explaining, but it has an impact on the caregiver. And then I was a sandwich generation caregiver. So as I was watching my mother unravel, my children were watching me unravel. And so it has an impact on a person's employment. So if you're working and you're getting those calls from, even if somebody is placed in long-term care, it's really a disease that very sadly interrupts life. And when I speak to caregivers, probably one of the biggest stressors is the finances, because the more the disease progresses, the more care that is required, and there's a big financial cost behind it. And as we know from our healthcare system, dementia has a significant impact on spaces in long-term care, in the hospitals, et cetera. So it really has a big ripple effect. The most important role that a family member has, though, when you're looking after a person, is really that of being an advocate. Because as the disease progresses, the person will lose their ability to communicate, to verbalize their emotions, to verbalize their needs, to represent themselves. And so along the course of this disease, our role as a family member is to advocate for their health, advocate for their medical appointments. You know, and oftentimes people think, oh, well, once the person is now placed in long-term care, I don't have to worry anymore. Just the contrary. You know, there's been a lack of resources even in the long-term care. So you're constantly trying to advocate for enough care for the person, whether they're at home or whether they're now transitioning into a care facility. And, you know, it's a disease that is always evolving. The average length is anywhere between 8 to 12 years. And that really depends on if a person has pre-existing health conditions. So if a person has cancer, they can pass away from cancer before dementia. If a person has heart issues, they can pass away from heart issues before dementia. But if they just have dementia, dementia is a terminal illness, and which I will explain how it evolves. However, because it is always moving along, it really requires a lot of patience with regards to taking care of a person, especially at the beginning when the person is still able to communicate and they may be repeating themselves and asking the same questions over and over again. It requires a lot of creativity as the person is losing their insight and their ability to manage their activities of daily living. So you have to really be creative with them. And it requires a lot of empathy. And it's really about stepping outside your own personal needs and your own personal wishes and trying to always figure out what are the needs of this other person. Unfortunately, there is currently no cure. So once a person is diagnosed with Alzheimer's disease or other forms of dementia, there is no turning back, okay? We're going to hear a lot about in the news right now, hope. There is medication that will slow down the progress. But there's right now, in terms of, you know, certain medications, that Health Canada, as compared to the US, has not approved any of these injection medications that are trying to remove the plaque from the brain, because there's a lot of risks. The new medications that are coming out are given intravenously. It has to be given every 3 weeks, and there's a very high risk of stroke or brain bleed. The current medications that are available on the market are really there to try to slow down the progress. So we're talking about buying months. And, you know, unlike cancer, when you have chemotherapy and it could put the disease into remission, there's no such thing with dementia at this point. So what's most important is knowledge. You have to always be one step ahead at all times of the disease. So if you're in the early stage, you want to understand what's coming in the middle stage. If you're in the middle, you want to prepare for the late. You also want to be very knowledgeable about all of the resources in your community that can support you, whether that be not-for-profit organizations or hospices like yourself, or for-profit home care agencies, because people will need that extra help at home, because unfortunately the government, the public healthcare system just can't provide enough hours as the disease progresses. So I had no prior affiliation with McGill University. I spent a lot of years in Montreal as a volunteer. I became a real passionate advocate about the importance of education, was involved with quite a few community organizations, but I was becoming very frustrated upon hearing from families that they weren't being given the knowledge and guidance that they deserved when receiving a diagnosis. And I knew that in my city, I had one of the best medical schools in Canada, and I had already been invited as a guest lecturer in 2011. And I had the great opportunity to meet with the former dean of the Faculty of Medicine in 2017 and said, could I come and teach at McGill? Can I teach the medical students about post-diagnostic management and care? And the dean at the time says, well, you know, McGill's very interested in developing a community outreach program. Would you be, you know, interested? And so I started with that, and then, you know, it's been almost 10 years, but I am now embedded in the medical curriculum and teaching the medical students, in addition to teaching the community. So I'm not a medical doctor. My focus is really on the non-pharmacological approaches, but I was very fortunate that McGill assigned some of their best doctors to me. So I work on the left here with the yellow bow tie is Dr. Serge Gauthier. He's a world-renowned neurologist. He's retired from his practice, but he's with the co-academic lead of our program. He is an Order of Canada recipient, and he's really internationally known and still is quite active and working with regards to pharmaceutical companies, and does a lot of lectures for us as well. And the gentleman in the middle is Dr. José Moret. He's a geriatrician, and he's head of the Division of Geriatric Medicine for McGill. So we really work as a team and complement each other's work. So today what I'm going to be talking about is a lot of the frequently asked questions. And as Diane mentioned, we were the authors of the World Alzheimer's Reports. And we had to conduct surveys from not only patients and caregivers, but from healthcare professionals all around the world to understand their level of understanding or not about dementia. And what came out loud and clear is that most people don't understand the early signs and symptoms. Why is it important to seek a diagnosis? A lot of people say, well, if there's no cure, why bother going to see a doctor? So I'll talk about that. The pathway, how do we get that diagnosis? What is the diagnosis? What does it look like? How do we manage those challenging behaviors that present themselves, right? There could be a lot of verbal aggression, physical aggression, sexual aggression. So how do we manage that? What are the safety concerns that this disease that the disease presents? What are the good leisure activities that people could still participate in? And I'm sure that it must be the same situation in BC. I mean, and in Quebec, nobody knows how to navigate the healthcare system. How do you access home care support? How do you access the public long-term care? What are those tax credits, right? So nobody knows how to access the support, right? And that wasn't only a national issue, it was a global issue. Like these are global questions, right? And I think most importantly, caregivers don't recognize their own limitations, right? When does it become too much? When do I need some help for myself, or when do I need to consider transitioning from home into a long-term care? So to begin, dementia is an umbrella term, okay? Because a lot of people ask the question, what is the difference between dementia and Alzheimer's disease? Dementia is just that global term. So same thing, like if you say to me, you have cancer. Next question would be, what type of cancer do you have, right? So you could have bone cancer, breast cancer, all kinds of cancers. It's the same thing. If you have dementia, you may have Alzheimer's disease, you may have Lewy body, you may have vascular, frontotemporal. So dementia is just that overriding word. Alzheimer's disease is the most common form of dementia. It's the one that accounts for about 70% of dementias. Lewy body is often associated with a little bit of Parkinson's disease. In Lewy body dementia, people tend to hallucinate a lot more. There's a lot more rigidity. They could be waking up at night, quite confused and thrashing about. Vascular dementia is often associated when a person has had a stroke or a heart attack. So it's really all about what's good for the heart is good for the brain. So most of the time when you hear of a person who has vascular dementia, they are more or less likely to have suffered a stroke. Frontal temporal dementia really affects the person's personality. Most often it occurs in men, could begin as late as their late 50s or early 60s, and it really causes a significant change in their personalities. And then when we look at other dementias, I mean, there's alcohol-related dementia and what we call early onset, which is really difficult, where you have people who are under the age of 65 who have what they call the early onset dementia. So a lot of people also ask the question, what's the difference between normal aging and dementia? Okay, so as we age, and especially among women, we go through changes in our life. So for example, after giving birth, they say we have that mummy brain, or when we go through menopause, we're losing estrogen. So we become at times a little bit more forgetful, okay? And also, for everybody, if you're going through high stressful periods in your life, you may find that you're forgetful, right? That you can't keep track of anything. So that's normal, right? And it's normal to forget people's names. I mean, I meet so many people, and people come up to me, and they all know me, but sometimes like I recognize their faces, but I forget their names. But there's a difference if these are members of your family, people that you work with, people that you meet and play bingo with or bridge on a regular basis, and all of a sudden you don't recognize them, okay? Or again, if all of a sudden you are playing bridge regularly, or there's things that that you've cooked regularly, and all of a sudden you don't know how to do it anymore. So that's a problem, right? Again, and as we age, we're a bit slower to process things, right? Like if too much is going on at once, like I'm finding now, I'm in my late 50s. I find that when I'm in a loud restaurant and trying to catch up with it, like it's hard. Like it's just, I get so overwhelmed, right? So it's normal that as we age, we're processing things differently. Sometimes I'm looking for words, but it always does come back to me at some point. You're chasing those words. I'm always forgetting my glasses, losing my keys. Like that's normal. But it's one thing if you start placing your keys in the freezer, okay? And when you're healthy, when we talk about good judgment, is you normally are able to think before you speak or think before you act. And a good example would be, we are all being so inundated right now with these fraudulent texts, and the RCMP has wanted to come and arrest me. I don't know how many times, right? They've called, and we get these phone calls or we get these texts, and so when you're still healthy, you're able to pause and say, I'm not sure about this, okay? Or when you're at a dinner party and you see somebody that you may not necessarily like, in your head, you're like, oh, I can't believe that person is here. I really don't want to be with them. When you have dementia, you don't pause before you act. You just act, okay? You cannot think logically. So there's so many people, and I'll talk about finances later, that get caught up in these scams because they don't have that ability to pause and think. They do things impulsively. Or with regards to the judgment, they'll see somebody and everything that they see just comes right out of their mouth, okay? I never liked you. Did you put on weight? I don't want a Black person working for me, though there's a lot of racist comments that happen. So there's no more judgment, okay? And finally, when we're healthy, we're able to function independently. We do our activities of daily living. We're able to cook our meals, get dressed, so we're functioning, okay? So what's happening with dementia across Canada right now? Alzheimer's Society produced these really great reports in 2022 and in 2024 called the Landmark Study Reports. And it talks about how by 2050, the number of people living with dementia will almost be doubling, okay? And the majority of people who have the disease are definitely in their mid-80s. And why is the number so high? Well, as a population, we are aging. In the 1950s or 1960s, if you would have had high blood pressure, high cholesterol, many other forms of cancer, the modern medicine didn't exist. So many people passed away in their 50s. And if we're looking at how modern medicine works today, people are living longer, right? You can manage the cholesterol, the blood pressure. There's the cancer is getting much more advanced in its treatment. So people are living longer. However, dementia is also a result of aging. Okay, some people can develop, not everybody, but it is a result of aging. So hence that's the number. In my private practice, though, I do work with a lot of people who are in between the 70 to 74 range, and that's tough because in that age group, people are just beginning to take their retirement, or the grandchildren are starting to grow a bit, and you're like, okay, I can't wait to travel with my family, live my life, and then all of a sudden, one of the spouses gets dementia, and it really interrupts life. I recently have one of my dearest and closest friends of 25 years who's been diagnosed with Alzheimer's disease, and she's 62 years old. And that's very, very difficult. And when the younger you are, the faster the disease progresses. So that's been very, very challenging for me to witness. And I'm working very closely with the family. So it can occur at a younger age. So when we talk about risk factors, it is unfortunately a disease that everybody is concerned about. And the Lancet Commission has released last year what they call the 14 modifiable risk factors. So these are things in our life that if we learn about them earlier, I really believe that brain health should begin when we're actually even in high school or elementary school. But these are things that if we're able to properly take care of, we are going to be reducing our risk. Okay. So, and the way to look at it is what's good for the heart is good for the brain. So as I mentioned earlier, people who have vascular dementia have often had a stroke. Why do people suffer strokes or heart attacks? It's because they're not taking good care, right, of their heart. So what's important? Physical activity is extremely important, and it's recommended to do about 150 minutes of physical activity a week. So it's about 30 minutes a day, and 20 to 30 minutes a day, and you know, walking briskly would be wonderful, and maybe combining a little bit of strength training with light weights or Pilates, but anything to do with really keeping your, you know, some good muscle strength. Okay, avoid smoking. Really moderate the alcohol consumption. And it's preferable to drink red wine as opposed to white wine or rosé. There is a correlation with some air pollution, depending on, you know, where in the world people live. Very high relationship between concussions or brain injuries and dementia, Parkinson's disease, ALS. So, you know, when I hear about friends of mine who have kids that have had multiple concussions, either skiing or playing hockey or rugby, I mean, after one or two concussions, there really has to be some decisions made about whether or not you should be continuing to do those sports, because there is a big relationship between concussions and dementia. What came out loud and clear was the importance of staying socially stimulated, right? Socially involved, socially engaged. So for example, all of you as volunteers, what you're doing, like you may have retired from your previous careers, but the fact that you're continuing to wake up in the morning and have a sense of purpose, having a sense of purpose is so incredibly important. There was a large number of people whose dementia really, really progressed quickly during COVID because of social isolation. When they talk about education, they feel that people that have a higher level of education have a lower risk of dementia because you spent more years learning. However, I believe that it's important to spend lifelong learning, right? You could have graduated just from high school or from college, but if you're continuing to learning new languages, I'm learning now Mahjong, this game that I'm finding so incredibly complex. You could learn bridge, you could learn new activities. So it's just important to keep, again, learning. Weight management, manage your blood pressure, manage your diabetes, depression or trauma. I do a lot of work also with the Indigenous population. And, you know, we talk about all of the trauma that they would have lived through because of residential schools or other life histories. It's important to manage that trauma. Veterans who come back from war, you need to deal with the trauma and depression, okay? And now we know very much so that there's a real big correlation between hearing loss, vision loss, and dementia. Because if you don't hear properly and you don't see properly, you're not going to be socially engaged. So we really encourage people, if they're having hearing problems, to manage that. And then finally, this year, they also added LDL cholesterol. So if you do have high cholesterol, it's important to take those statins. And you know what, sometimes we take our health for granted when we're in our late 40s and 50s and we get prescribed some of these medications. We're like, no, I don't need that. You do need that. Okay, so they say if you can manage a lot of this, you are able to really reduce your risk. Now, there's things we can't change in life. We can't change our genetic makeup. The genetic component is about 30%. Sadly, more women than men are more susceptible to dementia. But again, you know, if we could try to manage as many risk factors as possible, our chances are more positive. Okay. So what are some of the signs and symptoms? This is a chart from Alzheimer's Disease International. And so some of the signs and symptoms that would most likely appear. So people think that dementia is all about memory loss. It doesn't need to begin that way. It could begin with a significant change in personality. So when I mentioned earlier depression, somebody that was never depressed before and all of a sudden is becoming depressed. Somebody that may all of a sudden becoming very agitated, anxious, and they never had these symptoms before. So memory loss is really that these activities that you do on a regular basis and all of a sudden you find you're at a loss, okay? Like I mentioned earlier, unable to cook those meals that you did, you forgot the recipes, or you're not able, you don't remember your loved one's birthday or your anniversary, like really close family events that used to be very like milestone events, okay? Performing familiar tasks. So oftentimes when I use the when I used the example of cooking, so when my mother started developing dementia, she kept saying that she didn't feel like cooking anymore. She really didn't feel like cooking. And you know, it's easy to say, oh, you know, maybe some people say maybe they're just being lazy or they don't feel like it. But all of a sudden, cooking became too complicated. Organizing your finances, which I'll spend some time talking about. You know, but that person that used to love to have the family over every weekend and or was the one saying, I'm going to have or organize the Christmas parties or Christmas lunches, and all of a sudden they can't do it anymore because it takes so many steps to plan and organize those things. You will see a change also in how they're writing, their communication. You'll notice a big change in their speech. So in the early stages of the disease, the person starts searching for words, okay? Just common words like, where's my glasses? I want that. I can't remember. What is that? What is that? They're telling you a story and all of a sudden these words start missing a lot, okay? If a person speaks another language, they may start reverting back to their mother tongue language and mixing it up in the sentence. You'll notice a change in the handwriting. The handwriting starts to become quite odd or missing letters. You'll notice that if you're texting somebody, and that's what I'm noticing now with my girlfriend. I mean, she's having a very difficult time spelling. Disorientation with time and place. So they may think that we see a lot of times like, well, okay, there could be a mix up between day and night or forgetting, you know, that today at 2 o'clock I had an appointment. But then you will see cases where a person may have retired from work 10 years ago, and then suddenly they think that they're still at work, that they're getting up in the morning and they're going to work. They may forget that a spouse has passed away many years ago. They may wake up and think that they're in another city or another country, right? I explained a little bit about poor or decreased judgment. That's really, really about the person not having any filter. And that is a very difficult aspect for family members because for many people who have dementia, they really lose their filter. So my mother, for example, I had 3 young children and she would get overly stimulated when all the kids were running around when they were younger. And she would start saying, shut up, idiot, stupid, like just using these words that she would have never done before, right? Or, you know, we see a lot of times in the long-term care, or maybe when you're visiting you know, some of the patients, all of a sudden they may start being critical of you or criticizing you, and and it's hard for families because when a parent or a spouse starts attacking a family member, making critical judgment, you just can't take it personally. It's not them, it's the disease that is causing them to make these really unfortunate comments at times. And then keeping track. I mean, we normally, one of the first things that you start noticing is the person is no longer able to manage their finances. Bills are not paid. They may have overpaid a bill, overpaid rent, making a lot of errors and misplacing things again. You know, people might start losing their car, like really not remembering where they've placed their car, losing their wallet constantly. So it's not just about, you know, where's that pair of glasses? It's really about significant, important things that are now getting lost. And what happens oftentimes is when they misplace their things, they start accusing others of stealing, which is not uncommon. And then again, the changes in mood and behavior, I'll spend a little bit of time on that afterwards. And it's really the spatial visual. So dementia doesn't only impact our cognition, it has an impact on our vision. So when we're healthy, we have a really good peripheral vision. So when you're driving, you can, you know, you're able to react, you have that timing. But as the disease progresses, our vision gets narrower and narrower and narrower. So by the end, it's almost like a monocular vision. So you don't have those reflexes. It also impacts the way a person walks. So you may notice that a person is starting to shuffle their feet as they walk instead of lifting. They will approach a set of stairs and they'll say, huh, like, what do I do with these stairs? Whether it's 2 stairs or 10 stairs, getting in and out of a car, in and out of a chair. So it impacts all of their vision, or they'll walk past a mirror and go, oh, who's that? You know, and sadly, you know, depending on the type of personality, people start to withdraw. And I see a lot with couples, like I always encourage when a spouse is diagnosed, please tell your closest friends what's happening. Because if you don't share with your friends, They won't understand what is happening. The person is changing. They're not able to maybe participate as much in the conversations, but what ends up happening is people start to withdraw and they become isolated, and you cannot be socially isolated. So a few things with regards to my mother. So what I had noticed was really a change in her behavior. My mother was diagnosed at the age of 74. Most likely she began around 68. I grew up in a home where my mother was a caregiver to my father. I had no brothers or sisters, and I was a sandwich generation caregiver. And when my father started telling me that he was noticing changes in her, I blamed it on stress. I said, it's your fault. She was always taking him to doctor's appointments. He was putting a lot of pressure on her. So I was really at the early stages, I kept saying, well, it's because of all the stress of looking after him. But after my father passed away in 2005 of congestive heart failure, and I really started noticing her behavior. Like, so examples were those words that she was using. My parents lived in an apartment building, and she would stand at the peephole of the door every day because she thought that the mailman was actually a drug dealer. And she kept telling me, oh, there's a whole drug manufacturing plant as a neighbor, right? So there's these conspiracy theories that they believe. And she was really struggling with her words. My mother was from Finland, and she started speaking Finnish to me, and I never learned how to speak Finnish. And all of a sudden I'm saying, Mom, you're talking in Finnish to me. And she's like, I'm not speaking in Finnish to you. So it was a lot of her language. I noticed that, after my father passed away, I went into her apartment in her kitchen, and I started opening up some cupboards, and I found hundreds of empty plastic blueberry and strawberry and raspberry containers hidden everywhere. The food in her fridge was expired. She wasn't able to really cook that much. She was living off of these microwavable lasagnas, okay, until she wasn't able to use the microwave anymore. She wasn't able to manage her finances. She was making a lot of mistakes sending to charities. Like, I remember back in the day where every charity would send you these pens or these cards or these plastic bags, and you'd say, okay, for 25, please send us $25. And my mother was sending everybody $25 because she thought she had to pay for all these Christmas cards and these pens. So there was a lot of changes that were happening. And one of the challenges that I had at the time, which exists today for people, is because it wasn't truly memory related to the beginning, I said to myself, like, she needs to see a doctor, but I don't know what type of doctor to take her to. Maybe she needs a psychologist. Maybe because my father had passed away and her role was changing, I didn't even know where to begin. So we ended up going to see a family doctor, and then the family doctor referred us to a neurologist who diagnosed her with Alzheimer's disease. She failed I'll show you the tests a bit afterwards, but it was very clear that she had Alzheimer's disease, and that's when the whole prescription was, good luck to us, right? Which was very unfortunate. So I'm going to show you a few pictures, because if you don't know somebody who has the disease, it's not just about cognition, and it really goes through the 3 stages. So this would have been at my wedding. It's when she was first starting to notice some changes in herself. Okay, now, not everybody is aware of changes. Some people will have the disease and be in constant state of denial, but some people will most of the time say that I feel different. So at my wedding is when actually she said, I feel different. Okay. So at this stage, this is the early stage. So here she is diagnosed. So I want you to have a look at her eyes, okay, and her features. So she's diagnosed, and this is the stage where, like, you see how young my children were when they were running around. She was really becoming overstimulated. I also had 2 dogs. It was too much sounds, and that's when she would start acting out and saying, like, shut up, shut up, shut up. Okay, but she still looks fine. And what's hard for families is the person looks fine. And I was actually accused by some of my mother's friends of making things up. Okay? Okay, that's the middle stage. So at this stage, she is no longer able to live alone. So she went first to live in a private residence, because in Quebec, it was a 2 to 3 year waiting list to go into the public system. And honestly, in the earlier stages, it's better for them to be in assisted living, because the long-term care is for the final stages. Okay, so she was in a private residence, then she had to transition to the long-term care. But you see the difference in the eyes now, right? The difference. So here she's really losing her ability to communicate. She still knows me and knows that I'm somebody that's special to her, but she's not very verbal. But you see that the changes in the features. Finally, so each phase is about 3 years. So when we talk about end-stage dementia could last 3 years. It's not like end-stage cancer where we're talking months. End-stage dementia, it could be years. So this stage was, again, about 3 years. At this stage, not very verbal. She had to be in a wheelchair full-time because she kept falling. Very confused, needed 24-hour, 7-day-a-week care, and not too sure who I was. Like if you look at the photos, like she wasn't 100% sure of who I was, okay? And, it gets to the point where this was just a couple of months before she passed away. People would ask me, should I continue to bring the grandchildren or your children to see her? I brought them because I knew that, there wasn't a lot of time left. It became tough for my girls to go on a regular basis because on the Alzheimer wards, there's a lot of smells, a lot of sounds. It could become very disturbing. So it depends on the family. My son was very close and it didn't bother him, but he was older. But it was scary for my children at that point because depending on some of the patients and how they were. So you can see for families, having seen these images, how difficult it can be. So, you get this diagnosis and first you're mourning the communication, you're mourning that cognition, especially for couples, that you can't sit down and really have those meals. But then as it goes through its journey, you're really witnessing all the physical changes that are happening. So my journey with her was 10 years. And it's 10 years and you're witnessing that, what we call that anticipatory grieving, the constant loss of the person. So if there's no cure, why bother seeing a healthcare professional? Well, there are many reasons why. So first of all, when an older person starts developing symptoms, it could be that they have other health conditions going on, right? It could be some of the symptoms are as a result of loss of hearing. So if a person all of a sudden starts becoming more isolated or not maybe participating as much in conversations the way they did, maybe it has to do with their hearing. Sometimes symptoms of dementia could suddenly come on and it's not dementia. It could be delirium and it could be caused by other conditions like dehydration, and a bladder infection. There's all kinds of other things that could all of a sudden, like chemical imbalances. Maybe they were just prescribed a new medication and all of a sudden it's not agreeing with them. So they really need to have a proper assessment because in general, somebody in their 70s and 80s has what we call these comorbidities, other health conditions that need to be properly managed. The other thing, the importance of why you have to see a doctor is as a result of the disease and its progression, there will come a time a person will not be able to manage their finances anymore. A person may not be able to drive anymore. And the decisions to help the family, to help the patient stop managing their finances or driving has to come from the doctor. In Quebec, in order to access home care support from the public system, you have to have had a medical evaluation. You can't just call up our local public health authority and say, I need home care support. You have to have a medical evaluation, okay, in order to do that. And again, because the disease really could present some challenging behaviors, so aggression, paranoia, hallucinations, there are what they call mood modifying medications that could help with that. So my friend right now is having tremendous amount of hallucinations and paranoia and anxiety. She doesn't need to suffer like that. So we are trying to get her to see a doctor, the neurologist, to try to manage some of that, right? So even though there's no cure for the actual progression of the disease, there are ways to treat anxiety, depression, and hallucinations and some aggressive behavior, okay? But I would say most importantly, most families have to get at some point a power of attorney or a mandate to be able to represent the finances and legal affairs of a loved one. And you have to have a medical evaluation for that. You can't just go to a notary and lawyer and say, this person can't manage their finances. Can I just have a paper? Like, no, you have to have an official medical evaluation. So how is the evaluation done? First of all, like any other disease, the doctor is going to ask you for your medical history, the list of medications. But what's most important is the list of signs and symptoms. Okay, so it's everything that I have kind of explained. Like, how is the memory changing? Has the mood been changing? Are they able to manage their finances? Are they able to dress themselves? Are they able to feed themselves? Like, what has changed? And I really recommend sending this list of symptoms that families are noticing prior to the medical appointment. Because if you are sitting in front of the person and talking about them, it's terrible. And many, many people who have dementia have, which I'll talk about afterwards, is called anosognosia. They are in complete denial. They don't believe anything is wrong with them. So you really want to prepare that list and try to send it to the clinic prior to the medical appointment. You also have to remember that right now in our healthcare system, if you are seeing the first step as you normally see a family doctor, the family doctor has to see 6 patients per hour. That means you have 10 minutes. Okay, if you're for the first assessment, you want to arrive prepared with your list of questions and all of your information, right? And sometimes the family doctor may be able to perform the cognitive tests. But in many cases, the doctor will say, okay, I'm going to give you a referral to see either a neurologist, a neuropsychologist, or a geriatrician. Could be one of those, okay? Unless the family doctor could do it themselves, okay? And sometimes there are geriatricians who are really specialized in neurology, or sometimes you'll see just a neurologist. If you're lucky, you'll actually meet a geriatrician who specializes in neurology, because the geriatrician is essentially a family doctor who looks after patients over the age of 75 and will be able to assess all of you as a whole being, as opposed to just the brain, okay? And then so this is really the first, the information they're gathering. They'll ask if the person has audio, visual, are there any other aids that they're doing? If it's not the first appointment and you're having repeat appointments and the person it's clear they're having challenges driving or managing their finances, you can ask the doctor to help recommend that, they have help with their finances. If need be, the doctor may have to send the person for a driving test. And you should also be asking them for information about the disease, as well as what are the resources in the community that could support you, okay? So after they gather the information, I mean, this is the most famous test. It's called the Montreal Cognitive Assessment, the MOCA. It's available in over 120 different countries and languages. And depending on the country, the images may change in terms of the animals, or, because they really try to make sure that it's culturally friendly. This test actually is now available online. It's called MOCA Express. And you can actually go and do your self-testing. It's not like, it's a little bit different. It was just launched. But I would advise you that if you do that, make sure that you have some psychological support if needed, because the scary thing of allowing people to assess themselves on their own is you don't know what happens if you get the results of the test. So this is really the most common test that you'll have. And then they'll do some blood work. It was just announced that in the US, they're able to now detect almost 100% with a blood test if a person has Alzheimer's disease. So they're becoming much more advanced just with the blood tests. So again, depending, this test hasn't come yet to Canada, but it's expected to be approved. But so they'll do a blood work, okay? And then in many cases, the person will be sent for either a CT scan or an MRI. So they're looking for signs of stroke. They're looking for signs of plaque in the brain. But sometimes just based on the information, the symptoms from the family, the blood test and the cognitive test, that may be enough for them to make a diagnosis, okay? But truly what should be happening is this type of complete workup is about 90 minutes done by a neurologist. So it's either CT or MRI. And then in some cases also, they may do a spinal tap. Okay, and what they're looking for really is abnormalities in the brain. Okay, signs of glucose or tau in the brain. Okay, as I'm not a doctor, normally Dr. Gauthier does this part to explain, the different aspects of the brain, but that's what they're really looking for with the scan. Okay, so then they get all of that information and they put it together, and depending again on the symptoms, they will be able to say what type of dementia. So as I mentioned before, Alzheimer's disease has some classic symptoms. Well, if it's vascular dementia, normally there would have been signs of stroke in the MRI. But my mother, for example, had vascular and Alzheimer's. Okay, so you could have mixed dementias occurring, right? Sometimes it's hard for them to be accurate and say this is exactly the type of dementia. What we do know that is that more or less, the dementias all have very common symptoms, except for the ones where there's more hallucination. So as I said earlier, with Lewy body, you've got more hallucinations and paranoia. But how we lose the cognition, how the disease moves through its stages, and first it impacts cognition, and then it takes away the person's ability to manage their activities of daily living. Then it impacts, they become incontinent, they need more care. All of that stuff, it really progresses more or less in the same route, right? So now we're going to get into the safety prevention, because that's what we're very concerned about. And, as volunteers and you're visiting people's homes, there's a few things that you want to look out for if you're concerned that somebody may be having signs of dementia. Okay, so every room in the house, and afterwards, I'm going to show you a great resource that you can go to. You'll have full access to it free. So you don't have to take notes, because we've done a comprehensive overview of this in this booklet. Every room in the house has some dangers, but as I mentioned earlier, what you want to look out for is because it affects the person's vision and the mobility. If there's loose carpeting lying around and a person is beginning to shuffle, that's really dangerous. If a person suffers a fall, it can make the disease progress. Like any type of physical trauma will make the disease progress much faster. So we want to look for carpeting, loose carpeting, cords that are lying around in every room. The kitchen is a very dangerous place, because somebody with dementia may forget to turn off the stove, put things in the oven that they may forget, put things in the oven or things in the microwave that should not be put in the microwave or should not be put in the stove, forgetting to use oven mitts to remove things. A bottle of Lysol may be mistaken for a bottle of olive oil when cooking. Food that you may notice, food that's expired in the fridge, molded things in their cupboards. So, I'll show you some pictures afterwards of what, like very messy, like very, very messy kitchens, like garbages that weren't emptied, recycling bins that weren't emptied. Okay. The bedroom is probably where most of the falls happen. If people get out of bed in the middle of the night, they're feeling a little bit confused. Is there clothes on the floor, slippers by the bed? We want to watch out for cigarettes that are still burning by the bed, medications by the bed, glasses of wine by the bed. It's not unusual for a person to change their clothes multiple times a day, and then you'll just find everything that's down on the floor. And in the bathroom, we really want to try to safe-proof. I mean, even healthy people, how many people have those anti-slip mats in the bathtub or in the shower or the bars? And, the whole mobility of even a person lifting off the toilet seat, they may lose their balance. And, just shaving at some point could become dangerous for somebody not knowing how hard to press. So every room, and again, we have this booklet for you all that will really show you what things to keep an eye for. So dementia can cause hoarding. So I don't know if any of you may have seen this along your journeys in people's homes, but especially among people who are living alone, they tend to have, not everybody, but many people may tend to start accumulating things, okay? Accumulating, but it's because they're not able to let go. They're not able to get rid of things. They collect, but they can't sort, okay? So this I've seen this quite a few times. I used to do a lot of home assessments, so this is what I would see. And when I was talking about the bedroom you may find, I mean, not to the extent, this looks like a teenager's room too at times, but there will be stuff around, there will be stuff on the floor, okay? It will be messy. But the pharmacy in the bathroom is the most dangerous place, because somebody who has dementia should not be left unsupervised to take their medication. And I always get this from families that, oh, my mother, my father, my husband or wife, they're not taking their pills. You really have to give them their pills. And the dispill doesn't work Because at one point, as the disease progresses, the person's not able to read the words. Okay, you could see Monday 2 o'clock, Monday 10 a.m., but they don't understand what that means. And so a case like this, people will take too much medication. They may take the wrong medication. People could tend to brush their teeth with cortisone or polysporin instead of toothpaste. So what I normally do is I would go in and I would have a really good look at somebody's medicine cabinet, try to clear out anything that's expired, anything that's not needed. Some people have their medicine cabinet located in their kitchen or their bedroom, but it could be very, very dangerous for the person. Okay. And the other reality that people really need to be aware of is the impact of dementia on eating. So it causes changes. So it begins with the person is no longer able to prepare their own meals, right? They may say, I don't feel like cooking. I don't feel like cooking. Well, there's a lot of steps involved in going to the grocery store, going and selecting your food, reading the labels, getting to the cash, paying for the food, getting home, opening it up, preparing. There's so many steps involved that disappear with this disease. So that starts that they may not be eating as regularly. Then you may notice that they're using their hands to eat certain foods. So yes, we use hands when we eat bread or maybe there's certain other items, but if all of a sudden you notice that they're using their hands to eat their steak or their chicken breast, that's a warning sign, okay? That you need to start cutting up their food for them. And then if you start noticing that they're playing with their food where they're not chewing it properly, it's just staying in their mouth, you have to be careful. Because normally, if a person is at the stage where they're starting, like if they're in a long-term care facility, there's normally nutritionists or occupational therapists on hand to pay attention to this. And when they notice those things, they switch the person to soft food. But if you're caring for somebody at home, you really have to be careful because they don't know how many bites it takes to swallow certain foods. Even the little Laura Secord chocolates, we know it's 2, 3, 4 bites. Sometimes people could put the whole thing in their mouth and try to swallow it in one shot. So it's to really be careful. And how do we know that when a person is actually getting to the end stage of dementia, again, that 3 years, it starts with the eating. So you see a big change in how they're eating, how they're swallowing, because the way that a person passes away from dementia, there's normally one of about 4 ways. So first of all, the natural course is that the body is starting to shut down. The person is now losing all their motor skills. And at the end of the day, the person just can't swallow anymore, okay? And it doesn't happen from one day to the next. You're noticing they've been put on puree. They're having more difficulty even using a straw, even swallowing water. And then all of a sudden, they just can't swallow anymore, okay? The other way that people pass away is from an infection that is undetected. So for example, the largest number of people who died during COVID were those that had dementia because they couldn't express in the care homes that they weren't well. Could be a bladder infection. It could be as a result of a fall. But the natural course of the disease is really the body just shuts down and they can't swallow anymore. So it's important to keep an eye on the person's eating. The other part of safety, what we are seeing more and more is really the financial abuse. Again, we're all getting solicited by these crazy texts, UPS, which is not really UPS, or Amazon, or Netflix, or all of our bank, right? And the problem is that if you make the mistake, you can't get your money back, right? And so for a family that has a loved one who has dementia that is still managing their finances, if they've just sent $5,000 or $10,000 off to some fake person or fake charity, and the family member doesn't have the mandate, you can't call up the bank and say, oh boy, no, I think my mom, she's starting dementia. We just lost $10,000. Could we get our money back? It doesn't work like that at all. So and the seeds of dementia often begin with people making financial errors. You see they're having more and more difficulty paying the bills. They forgot to pay bills. They're sending too much money. I've seen, sadly, there's all kinds of scams. There's romance scams where you start getting these texts and, some people who are living alone believe that, oh, well, look, this person wants to go out on a date with me, or this is Donald Trump or Mark Carney texting me and asking me to come to their place. And for $500, I get to go to the White House or I get to go to Ottawa. Like, people believe in those things. And then I've seen, unfortunately, family members steal as well, like signing over, like if it was a couple of siblings and that the parents had a cottage, and one of the siblings goes and forces the parent to sign that cottage over to them. Okay, so financial scams could even happen within family members. So it's very, very important to make sure that if you're starting to notice that the person is making financial errors or really poor financial decisions, investing in things that they would have never done before, lending people money, going to the bank and withdrawing over and over again, you could set credit limits. So, you could set a limit on a person's debit card. You can change the limit on their credit card. But a lot of people end up having these unbelievable spending habits. And if there's nobody in the family representing them, the money's gone. Okay. And so we have to be careful. The other issue that we face is wandering. So especially for people who are living alone, they get confused. What day is it? What time is it? Some people tend to sleep more during the day and then they're awake at night. Every week in Montreal, we hear about a senior who's gone missing. So if it's a couple living together, it's also not unusual that the healthy spouse may be sleeping in a separate bedroom because they don't want to always be awakened at night. As the disease progresses, a person starts sometimes to wet the bed, so it's uncomfortable for the spouse, so they sleep somewhere else. So if the person gets up in the middle of the night, they don't know. So I always recommend that you try to have an alarm system that's armed, or those chimes on the doors when you open it to know that a door has been opened. And I'm recommending now to all the families that I'm working with the Apple AirTag. The Apple AirTag, that's what we put in to find our luggage. I don't know if everybody knows what that is, but it's like a round, it looks like the size of a loonie, and you can trace it from your iPhone. So a lot of families are putting the AirTag onto people's house keys. Okay, if they're going out, you could hide it in a car, you could hide it in somebody's jacket or a purse, but it gives you the ability to really locate that person like almost immediately if you're within range, unless you're, as you mentioned, Doreen, if there are people living out in the bush, I don't know if there's Wi-Fi access out there, but under normal circumstances, you should be able to locate the person. Okay. And then driving, as it progresses, the person won't have the same reflexes. They can get lost. A lot of people say, oh, they're able to go to the grocery store. That's great. But what happens if there's a detour? What happens with the crosswalks? If a dog suddenly runs into the middle of a street or a child runs into the street. So the decision to stop driving really has to be made with the doctor. And every time family members try to take the keys away themselves, it just causes tremendous conflict. So what's the big impact on the family? Well, first of all, anosognosia. So anosognosia means that the person who has these symptoms really has a loss of insight. They do not believe that anything is wrong with them. And what happens is they start accusing their family members of making things up. You're stealing from me. You're cheating from me. You're just trying to put me away. You never come and see me, right? You don't love me anymore. They really, really, truly don't believe anything is wrong. And because of this, it's hard to take them for that first medical appointment. So you kind of have to be a little bit of creative and say, look, we're both going for our annual physical checkup. We're both doing this, but anosognosia is very, very, very challenging for a lot of families. And the seeds of dementia are often planted years before diagnosis is made. So the example I like to give now is about Bunny the cat. So once upon a time, I had a 4-year-old cat named Bunny. And when my son was really young, my mother loved this cat. So I brought the cat and my son first to stay with my parents while my father was still alive for a weekend. And after the weekend, I went back and my mother gave me my son. And I'm like, where's my cat? And she says, the cat is dead. I said, what do you mean the cat is dead? And she says, well, I brought the cat to the vet and I thought it was best that I put the cat down because the cat was scratching the wallpaper and your father was getting very upset. And I was completely shocked and devastated. And there were no words. So a few years ago, I was having this aha moment because they always say there's always a moment where you know when it began. And I had this aha moment. I'm like, it was then. That's when it began because it made no logical sense. And it was shortly after that other odd things started happening. But that was the defining moment where I said to myself, this is when it began. So she was diagnosed in 2006, and the issue with the cat happened in 1998. Okay, and it was shortly after that there were always these little things happening. So dementia, what we have to be careful of with regards to family members, and again, yourselves, if you're working with families, is that not with everybody, but you may notice that people may become verbally inappropriate, verbally aggressive towards you, complaining, criticizing, making inappropriate comments, okay? And that happens. Unfortunately, what we see with families is that the spouses or kids don't know how to handle it, right? So if the person with dementia starts telling their daughter or their son, you never come and visit, you're a terrible son, you're a terrible daughter, or they're telling their husband, you're cheating on me, the reaction is to go, well, what do you mean? I'm not doing that. Like, you right away, you want to react. And if you react, depending on how you react with the person that has dementia, in many cases, they could become physical. They could get so frustrated with you that they could throw a cell phone, they could throw a remote control, they could begin to hit, bite, kick. So when I'm working with families, I'm always trying to assess, is this person displaying any type of verbal behavior, aggressivity? If the answer is yes, I always ask, has it ever become physical, right? And if so, how physical? And it's really deciding what type of verbal behavior is there. Is there hallucinations? Is there paranoia? Because if there is, then it's important to seek medical attention. Is the person really depressed? Is the person really anxious? You got to seek medical attention. If the person becomes extremely physically aggressive, you have to call 911, because we don't know how that physical aggression could turn into, okay? If they could wake up in the middle of the night, they're confused, they don't recognize their spouse, all of a sudden they could start to choke the person, punch constantly, kick constantly. So if it becomes too aggressive, we have to alert the authorities, okay? And it's really important that the person be brought to the emergency room. So challenging behaviors often happen for certain reasons. So as I mentioned earlier, as the disease progresses, you're going to lose your ability to communicate, use your words, express your emotions, express your feelings and your needs. So imagine if you're hungry or tired, or you're constipated, or have a terrible headache or something, and you can't tell your family member or your caregiver what's wrong, right? You can't tell them, and they're not understanding what's wrong. You will become frustrated, okay? So if you're working with these types of people and you show up at their home one day and they're really having, like, they're not happy, you have to almost become like a detective, right? So where you start when you're working with a patient with dementia is know who the person is. What are their triggers? Like, what do they love? What is the music they love? What is the food they love? Do they like to be outdoors? Is there certain, like, what do they really love? But what do they not love? Right? Is there music from the past that could trigger a terrible emotion? Are they Holocaust survivors? Are they war survivors where maybe the sound of a violin will upset them? Is there a family member in their life that every time they come over, it gives them a bad reaction, right? Maybe they're so bored. They've been sitting in their chair for 6 hours a day and now they're wet and they can't tell you they're wet. Maybe they've gotten up and they've knocked themselves into a wall and they've cut their leg and they can't tell anybody that, right? So you have to be a detective, like, what is going on in their surroundings that could be causing it. But it's also the disease itself, right? And oftentimes challenging behaviors happen because of how we react, right? We have to pick our battles. So if you're constantly telling the person, why are you dressing like this? Why are you talking like this? Why are you setting the table like this? Why are you doing it this way? Of course, they're going to get frustrated, right? They're doing all of that because they have a disease. So it's not up to the patient to change. It's up to the family members and caregivers to change, right? And when I'm saying caregivers, I mean, like, it could be volunteers or professional caregivers changing. You have to adapt to them. And because it's a disease that's ever evolving, the strategies you're going to put in place today are going to be changing every 6 months, right? So maybe one day their routine is they enjoy having baths and showers twice a week, and then maybe they're not going to want to have it twice a week. Maybe it's only once a week. Maybe they used to love to go for walks every day. Maybe that's going to change. So you have to always be adapting to where they are on their journey, right? And if they're telling stories where, if they said we went on a honeymoon in Spain and it was actually Italy, who cares? If what they are saying or what they are doing isn't hurting anybody, let them be, right? If you're spending all your time correcting them, it's a problem. So we really say join their journey. And then finally, it's about using a compassionate lie once in a while. So if the information that you're going to tell them has the potential to cause a catastrophic reaction, don't do it. So if you tell them, like they say, well, where's my husband? And the husband has passed away 10 years ago or 5 years ago, and you tell them your husband has passed away and they completely become traumatized. Maybe it's better to say, oh, don't you remember your husband went off on a business trip and he'll be back in a few weeks, right? Or because you have to think, because normally they can't retain this information. So if they keep asking you and it's traumatic for them, why do it? Okay, so it's about really thinking about how you're going to say it. Or if you need to take them to see the doctor, you don't have to say, well, I'm taking you to see the family doctor because I think that you may have dementia because your memory and you're driving me crazy. As opposed to saying, let's go for our annual physical checkup. And, we may even have a brain exam, the two of us, but just think before you speak. Okay. And it has a big impact on families with regards to the relationship. You can only imagine that for two spouses, again, the healthy spouse, once upon a time you had this romantic relationship with a person, or you used to sit down and look forward to catching up about your lives, or having the grandchildren come over, or talking about the next trip that you're going to have. And then all of that changes, right? You can no longer have those dreams together or have those conversations together. And then all of a sudden the husband or the wife becomes kind of like a parent where you're having to care for this person. And then sometimes these boundaries where you're even changing them and bathing them, right? And same thing for sons and daughters. Once upon a time, your parents took care of you, and then now you're doing all these tasks as if they were your child. And I see a lot of times where, for example, I'm working with a family in Quebec, and the daughter lives in Quebec, but then the son or other siblings may live in BC, or may live in Calgary, or may live in the US. And the child in Montreal is like resentful because they're like, well, I'm the one that's doing everything. My brother and sister are never here. They don't even offer to help, but they're always criticizing me, right? So even if people live out of town, there are still things that they could do. They could help manage finances. Maybe they could help make some phone calls. Maybe they could come into town for a week or two to give the other sibling a break or the parent a break. But it causes a lot of stress in families when one or two people feel that they're doing it all and nobody else is doing anything, right? And again, it is very financially costly, because the more the disease progresses, you can only get so many hours of care from not-for-profit organizations and public system. And most families, if you want to age at home, they have to supplement with private care. And private care is about $38 to $40 an hour right now, if you're going through an agency. So I try to work with families a lot to say, like, we all have to be educated equally on this disease. It needs to be like an understanding. Everybody has to understand the disease, and everybody has to have their appropriate roles on how people can work together, right? And communicate as a team. And, the sooner you try to find help, the better, because if you avoid getting some support, the disease will call what we call the anchoring effect. The patient will only want their husband, wife, son, or daughter to be there and take care of them, right? And then it'll take a burnout before somebody finally says, oh my gosh, I can't do this anymore and I need some help. So you want to try to identify as much help as soon as possible. And inevitably, because of the way the disease progresses, we see older people caring for older people doing a lot of these physical tasks, right? Helping prepare the meals and dressing and bathing and lifting. And it just could become too much. And when I'm doing these talks in Quebec, I discuss a lot about how to access help from the Quebec healthcare system. So all I could say with regards to all of you in BC is you need to understand how your system works ahead of time. Don't wait for when you're in a crisis to say, okay, I can call the public health for home care support. In Quebec, to get a social worker just to come and do the assessment, it takes about 6 months. Then you got to wait many more weeks afterwards so that you're eligible for your 4 to 20 hours a week, right? The waiting list to go to the long-term care public is 2 years. And most people don't know that, right? And yes, there are private residences like there are in BC, but the private residences for full care is about $14,000 a month. And not too many people can afford that. So it's really to make sure you understand how to access as soon as possible the help. And, again, everybody wants to age at home for as long as possible, but sometimes you have to make the decision to transition. And it's a difficult decision, but, COVID taught us that in life you have a plan A and you need a plan B. So even if the family member makes you promise and swear that you'll never make the move, it's not fair to make that promise, because what happens if the primary caregiver passes away before the patient, right? Like, you just always need to know, what if, right? What if I can't take care of the person at home? What if they go to this private residence or this residence and it's not working out? What is another option? Because that also happens. You transition somebody to a assisted living facility and it doesn't work out. So you always need to know what your options are at all times. Don't just say, okay, they're there now and that's it. No, it may not work out that way. So always know your options at all times, and expect the unexpected. Like what I always say is, I was a sandwich generation caregiver, no siblings, and I had a very, very busy life. I had 3 young children, and, along my journey, everything that could go wrong went wrong. Nobody had warned me about the impact of, my mother needed to have emergency hip replacement surgery. And nobody had told me that a person with dementia who has anesthesia, that they could they could start hallucinating. So my mother had emergency hip replacement surgery that went terribly wrong. She suffered a heart attack post-surgery, a broken femur post-surgery. Then she had to transfer to a rehabilitation center for 6 months and was not able to be rehabilitated because she didn't understand the instructions, right? And, I've worked with hundreds and hundreds of caregivers over the past close to 20 years now. And my story is their story. Like, we all have similar stories about, things that can possibly go wrong, right? And this is what advocating of care means. My mother at one point was in a private residence because we couldn't get into a public one. And she was not happy. She was not clean. She wasn't safe. And I was advocating and advocating for a year and a half with the public healthcare system. And finally, I was able to get her out in June 2012. And just in a few short months, you could see the difference in her, okay? But you're advocating, you're spending so much time advocating on behalf of this person. And meantime, I'm caring for my mother, but I had 3 kids. And so my son was, he had his own accidents. He had an accident at camp. He had a broken femur that he was hospitalized for many weeks, and then had to have major surgery. And then he was in a wheelchair. And then a few years later, he was playing soccer and had his entire chin and jaw broken. And like, so you're caring for somebody, but on that journey, you've also got other things happening in your life, right? There's other people that are depending on you. And me, like many other women, unfortunately, we all think we're super women. We think we could all do it, or we could do everything on our own. I was one of the people that absolutely refused to accept help. Nobody in the healthcare system ever asked me how I was, but the odd friend that would say, could I pick up the kids from school? Can I help you? I was like, no, thanks. I'm all good, right? And so sometimes we push ourselves so much. And the biggest emotion that I hear from family caregivers, is anger. Like, that the anger that people feel. I'm so angry, right? And because you go through the denial, you go through the guilt, but then anger is probably the one I hear the most of. How could this have happened to me? How could this have happened to my mother, my father, my husband, my wife, right? Finances makes people angry. Not understanding the disease and how to access support makes people angry. And sometimes we have people caring for somebody that they really don't like. So there's all kinds of anger. And then I've seen and I've experienced it myself. We go through all of these coping mechanisms, right? Some people drink too much. Some people eat too much, smoke, exercise too much. And these coping mechanisms, because everybody has something, could become an addiction. And I loved wine, and it was that glass of wine to soothe myself. But then all of a sudden it became a bottle, or becomes a bottle and a half, right? And you're dealing with all these emotions that you're trying to say, I could do it on my own. And then one day you just can't, right? And that's when things lead up to burnout. And also, I feel that as a society, we don't provide support for after the person passes away. You know, I accompanied both my mother and my father to the end. I was alone with both of them in the hospitals, unfortunately. And there's no support. It's okay, brush it off, organize a funeral, like let's get on with life, right? But you've just lost this incredible person. And especially when you're in a caregiving role for so long, you don't know who you are anymore, or how else to be, or how to react. So I had to learn everything all over again. And I had to learn to not start I had to learn to stop panicking every time my phone rang, right? So my my final message before I get to the questions is really, you know, we caregivers have this tendency to put ourselves last. We don't give ourselves permission to have a life. I always hear from caregivers, oh, I'm exhausted. I have no time. I can't do this. I can't do it anymore. It's because you're not giving yourself permission to have a life. And I suffered a very severe burnout, and I had to completely, well, I needed medical attention, psychological support. I was diagnosed with post-traumatic stress disorder, but I call it post-traumatic caregiver disorder. And I had to really take a look at my life and say, what matters? Who matters? And, you know, my mother passed away almost 10 years ago. And every single time I get invited to give a talk, have lunch with somebody, have dinner with somebody, I say to myself, is this important to me? Does this matter? Do I want to go spend 4 hours with these people at dinner? And if the answer is no, it's no. Is this the type of conversation I want to have? You know, and if it's important, if it's, you know, something that I have to do, I'll say, well, let's just have a coffee instead. But I'm very, very, very protective of my time. And so I had the burnout halfway through my journey with my mother, and I had to totally reset myself and relearn what was important and what mattered. So to end here today, a lot of the things that I've shared, we've developed this amazing program where you can go online and you can access everything for free. One of our most important, so this is the website. You just have to sign up for our newsletter, okay, mcgill.ca/dementia. One of our most important resources is this Dementia Companion Guide, and it's available in 14 languages because dementia doesn't discriminate, and you can download it for free. Many printed copies are available on Amazon. It's $20 and it supports our program. If you were living in Montreal, we actually distribute the English and French copies throughout many memory clinics in the hospitals and to the public health authorities. And every time we do in-person public education, we arrive with our cases of books to hand out. But all these books are available to download there. And everything that I mentioned today is in this guide. So just, you know, if you can just download it on your computer or order a copy. And I've produced about 130 webcasts on all kinds of topics, including an amazing cancer survivor named Susan Weiner about her resilience. There's talks on Parkinson's disease. So it's not only just dementia related, it's on a whole wide range of different topics, and they're all on YouTube and you can access them. And then we have an online education program. It's 10 modules in English and French, and you can go at your own pace, and each module really talks about different aspects of dementia. And again, you go at your own pace and you can get a certificate of participation once it's completed. And this is a very interesting book. It's because people that are living with dementia really need to remain socially, leisurely, and recreationally stimulated. So this booklet you can download. It has 40 different types of activities for a person to do, depending on their level. And we also have, and so it shows you, like, you know, what type of activities that you could do with somebody at home, especially in the winter. And the person doesn't only have to have dementia. This could be for anyone. They're really fascinating activities. And we have 12 in English and French accompanying videos to show how to do a lot of those activities. And then we have some virtual support groups. One is a partnership with the Alzheimer Society of Montreal for spouses. We have a young caregiver support group, and we have this amazing interactive webinar with these two fabulous social workers that really dive into some difficult topics, you know, dementia hygiene or family conflict, and all of them have been recorded. So you can just go on our website and watch past episodes of that. And these are our social tags. And I'll stop sharing and stop talking and let other people talk. So thank you very much. Mhm.
Okay, thank you. Thanks so much, Claire. I see that Carol Ann has a question. So Carol, would you like to go ahead, please?
Hi. First of all, Claire, thank you so much. That was so rich and so information forward, and you're a terrific presenter and advocate. It's a question almost as much for Doreen as it is for you, and that is, as a volunteer for hospice, and I'm sure this is true for probably everyone listening today, we often interact with people who have no friends or family. I mean, essentially, they've either alienated or they've just drifted apart or their friends have passed on. They have no family on the coast that they can turn to. And so a lot of what you're talking about is the care that is afforded them is from their immediate family members. And so I think even for Doreen, maybe further conversations within hospice about how, as volunteers, we work with people with dementia when they have no family or friends. So I'll just put that out there.
Yeah, I mean, there are some organizations, and you'd have to look within BC. I know the Alzheimer Society of British Columbia is an excellent organization, and you could find out if they have any type of programs where they would send people over to that person's house. So that, because I'm assuming these are people that are not probably very mobile or can't get out, depending on the stage that they're at. So they may have, at-home visits where they could do some stimulating activities. So yeah, I would say that would probably be the best place to start, Alzheimer's Society of BC, and see how they could maybe connect you with some programming, because I know that the woman who runs it is quite very, very devoted to the cause. So I would start with that.
I think that that's a really, really good question, though, that Carol Ann has posed. And I think it goes along with there are many people who there might just be one partner who is providing all the support. And we do certainly have people that we're companioning in hospice right now who would fit into that category. And I think that the whole notion that you discussed, Claire, where people think they can do it themselves and they're not able to plan ahead or see how this might translate, and how that person who is experiencing the dementia, whatever the source or kind might be, becomes so dependent on that one person, and it makes it so terribly hard as things progress and become unmanageable, untenable for that one person who's supporting. It makes it so challenging to introduce new people into that person's life.
Yeah,
And I don't know how we address that, but we see that on a regular basis. I see some heads nodding because yes, indeed, we're supporting people in that position.
Yeah, and they don't want anybody in their home. They're suspicious. They don't want anybody besides their family member. And very, very sadly, it because, like I'm going through with my friend right now, is she's gotten to that stage where she absolutely must have some companion care, and she's refusing. So we've had to start the process of the homologation of the mandate so that the son is able to take over all of her, because she's alone. She's no longer married. And we're going to, because it gets to the point of, we know her safety is at risk, and we will have to force companion care, hopefully finding somebody that we think she'll like, or hopefully, and have her as much as part of the process as we can, but it'll take time. But you wish everybody would openly say, sure, I'd love to have a companion come in the house, but that's not the case. And sometimes it has to be done forcefully for the sake and safety of the person.
Wow.
Thank you so much for your question. Does anyone else have any questions that they'd like to ask Claire? I guess she did explain a lot of, she did provide a lot of information. So I'm really glad that you took the time to attend this webinar today. Do visit our website because there's a lot of interesting information on there. And don't hesitate to reach out if ever we can help you with anything. And as volunteers, we just want to thank you for the important work that you do.
Yes, absolutely. And feel free to reach out to our program anytime. And again, this book will be invaluable. Like, there's so much information here for you. So please download it or order a copy or.
Great. Thanks,
Thank you.
everyone.
Thanks so much. Oh, you have a question, Richard? Oh,
You're muted, Richard.
I think he left.
You mentioned at the beginning that it was going to be recorded. Is it possible
Yes.
to access that recording?
Yeah.
Yes.
So
we will.
I will, once I have the recording uploaded, I'll share the link so that you can access it and share it with your colleagues.
Perfect. Thank you.
You're
Well,
welcome.
thank you all. Oh, Ron, you have a question?
Claire, I can't leave this presentation without thanking you.
Oh, thank you.
Your enthusiasm. I had your screen off, but near the end I brought your screen up and you're using your hands. Your passion for this work just carried right through this whole presentation.
Mm.
And I can't wait to share this with my wife, with my
Oh.
sisters. Fantastic information.
Well, thank you so much. I'll be honest, I went through a really hard time. I was in a really dark place. When I talk about anger, I was a very angry person. And after I came through it all, I said, there must be a reason why this happened to me and happened to my mother and happened to us. And in all truth, I've been a patient of the healthcare system for a really long time myself. And I said, there has to be a reason. And I realize the reason. So I love what I do, and especially to educate other people so that you're better informed if you have to go through this.
Mhm. Well, big
Yeah.
thank you.
Well, thank you.
Claire, I'd like to echo what Ron just said. It was so informational and so inspiring as well, and gives a lot of hope that there are possibilities. And sometimes it's difficult to ask and how to ask for that. One quick question I have is if somebody that I'm companioning is talking about something that is urgent, but it is not real,
Yeah.
and how to be with that.
Okay, so just ask them questions. So like urgent, okay, so tell me, explain to me, how are you feeling? And oh, what, like try to ask, like, I don't know if you can try to give me the example, but if it's urgent and it's a hallucination, like it's something that's really disturbing, then they have, because when we say urgent, sometimes people hallucinate and think that there's a robber in the house, or there's a fire outside, right? So if it's really disruptive, but even if they say there's a fire outside, you could say, okay, just a minute, you stay here. I'm going to go and have a look outside. Okay. Or sometimes they have these hallucinations where they say, oh my gosh, there's ants all over the floor. So we'll say, okay, just a second, let me go see. And you'll say, oh yes, I see them. I'm going to go get the spray and I'm going to spray them. Are they gone now? Can you see they're gone? So
yeah.
play into it. It's almost like you have to play an acting role, like join them and
Mhm.
see how far you can get. Okay.
Mhm.
And then you will have to decide, like, if it's, if it's something that's really disrupting them over and over again, that's where you have to say, maybe this person may need a bit of like anti-anxiety or something. But if it's a thought, just join them and ask them questions about it and help me understand why are you worried, Yeah.
Yeah.
Because
Thank you.
to tell them it's not real, that's not good, because for them it's real.
Yeah. Yeah.
Yeah.
Thank you. That's helpful.
So thank you very much, Claire. I don't see any other hands right now or any other indication that people have questions, although I'm sure we will after the event. But this has been such a rich learning opportunity for us all. Thank you so much. And I think we'll be looking at the website, and I also think we're looking forward to getting the recording.
Yes. Well, thank you all, everyone, for coming today.
Thank you.
Thank you.
Have a
Okay.
good weekend.
Bye-bye.
Bye-bye.
Bye.